Hello, and welcome to the final event of the day, which is the public lecture. I'm Anne Rosser. I'm current chair of the Guarantors of Brain, and it's my huge pleasure to introduce our speaker today, Professor Nick Fox, who's internationally renowned for his work on dementia. So Nick's first degree was in physics and physiology at the University of Cambridge, and he then went on to study medicine at University of London and trained as a neurologist. His particular interest is young onset inherited dementias. He's Professor of Neurology and Director of the Dementia Research Centre at the Institute of Neurology in London. And as well as being a consultant neurologist in the UCL Cognitive Disorders Clinic, he also founded and co-leads Rare Dementia Support, which provides much needed support on rare and young onset dementias and inherited dementias nationally and also worldwide. He's well known as an expert in neuroimaging and has won many awards for his work. And interestingly, he was involved in the first immunotherapy trial for Alzheimer's disease some years ago now. So Nick's talking to us today about preventing Alzheimer's disease, prospects and challenges. Welcome, Nick.
It's a great pleasure to be speaking at the Brain Conference, and I'd like to thank the organisers for this invitation. My talk will touch on the prospects and the challenges in preventing Alzheimer's disease. I think it's an exciting and timely moment to discuss this. First, my disclosures. I'd like also to acknowledge my funders and also particularly the patients and the families who so generously contribute to research and make this research possible. So my focus tonight will be on the challenge of dementia. I'll touch on the modifiable and the non-modifiable risk factors. I'd like to cover how we might intervene with therapies to slow or prevent Alzheimer's disease and look at both the prospects for prevention and the challenges involved in doing so. Ideally, we'd like to prevent its onset. So I might start by quoting from Benjamin Franklin, who, when advising the people of Philadelphia that preventing fires was easier than putting them out, that an ounce of prevention is worth a pound of cure. And often, as in medicine, the cure and prevention are hand in hand. A word about dementia. Given this is a public lecture, dementia is one of the greatest challenges facing society. It involves disconnections at many levels. At the biological level, we have billions of neurons, trillions of connections, and these are very, very sensitive to damage and to degeneration. They are what make us the thinking human. And as these degenerative processes undermine connections, we lose the networks that are responsible for our thoughts and our memories. But dementia also brings other disconnections. As those networks fail, we lose connections with our past, what makes us ourself. We lose our learnt skills, our higher functions, particularly early. And over time, we progressively lose connections with the outside world, whether that's through employment or through external social connections. And ultimately, and most sadly, we lose connections with those we love most. So dementia is the challenge of our age in both senses of that word, because worldwide there's a new case every 3 seconds or so. There are multiple causes, but most of these causes have very long courses, and ultimately involve increasing dependence and social care needs. In the UK, there are an estimated 850,000, maybe 900,000 people with dementia at the moment. And the impact goes well beyond the individual, affecting families sometimes more than the individual in some ways, but also impacts on our health care, our social services and society. a quarter of hospital beds have people with cognitive impairment or dementia in them at any one time. Perhaps 80% of those in residential care have dementia, and the costs of that residential care are what really drives the cost to the economy, which has been estimated at around £26 billion a year in the UK. So we clearly need to improve diagnosis, care and support for those who have dementia at the moment, and we need to find effective treatments. And numbers will increase dramatically, as I will go on to show, as populations age, unless we can find ways of preventing dementia. And this is a demographic time bomb for aging populations around the world. Prevalence doubles with every 6 years of age over the age of 65. And so as populations age and the prevalence is so strongly linked to age, we see prevalence going from around 4% in the early 70s to over 40% in the 90s. And aging populations, particularly in the low and middle income countries, will drive a great increase in numbers in the coming decades. Just if I may take a step back and deal with what is often conflated, Alzheimer's disease and dementia. So while dementia is a syndrome, Alzheimer's disease is one of the causes of dementia. Dementia has been recognized for centuries, but our understanding of its causes has changed and improved over the years, as has our ability to diagnose them. Alzheimer's disease in part or in whole accounts for perhaps 50, 60, 70% of cases, a higher proportion in those with more elderly populations. But there are many causes and they often can coexist. The era of our understanding of diseases that have been defined pathologically by abnormal proteins in the brain that caused dementia began over 100 years ago. And Alzheimer's, careful observations here, Alzheimer on the left of your screen, and his famous patient, Auguste D, on the right there. He, at post-mortem, carefully examined the brain of this person with young onset, what turned out to be Alzheimer's disease. He noted an evenly atrophic or shrunken neurodegenerative brain, and he drew beautiful amyloid plaques there on the left, and he also drew these beautiful pictures of these intraneuronal tangles, tau-containing, as we now know, tangles, as well as the neuronal loss and brain atrophy. And his pictures match up nicely with state-of-the-art modern pictures of this pathology. And these pathological observations have, together with genetic studies, helped us to understand the etiology and the pathophysiology of Alzheimer's disease, with abnormal processing of amyloid precursor protein leading to these monomers of a peptide, a beta peptide, where longer peptides have a greater propensity to aggregate into dimers and then oligomers and ultimately become protofibrils and fibrils of the amyloid plaque, which Alzheimer drew. And in a way that we do not fully understand, this interacts with the tau pathology and other factors such as inflammation, leading to neuronal loss and then the cognitive decline that is so debilitating. And there have been many approaches to tackling elements of this, these different pathological features and intervening in the etiology and its progression. One I will talk about is to try and alter the accumulation and of the amyloid itself as a key initiating factor, and I'll come back to this. But Alzheimer made his descriptions at post-mortem, and for decades after that, our clinical diagnosis was imperfect, and really a diagnosis of definitive Alzheimer's disease could only be made at autopsy. And this was variably correct. These hallmarks of amyloid and tau being the pathological definition of Alzheimer's disease, historically. And I'll come back to how we now have the ability to make see what Alzheimer saw after death in life. So what do we mean by prevention? Do we mean that we need to intervene before the disease process begins at its very start? Or is it just before symptoms or before loss of functional independence? And all of these have meaning and a value and different strategies. We can address prevention by risk factor management, really upstream, and by therapeutic interventions all the way down this cascade. And some of these interventions need to occur at societal or individual level, certainly in the risk management. And history of medicine has shown major successes where prevention is better than treatment. Particular examples in infectious diseases, transforming real killers, such as cleaning water sources to prevent cholera, smallpox vaccination. And this would be referred often to as primary prevention, preventing disease before it starts. But we've also seen huge progress in other diseases, cardiovascular disease, cancer, and so on. But what will that mean for the diseases that cause dementia? More recently, of course, we've shown how we can, as a society, manage risk in COVID-19 with face masks and lockdown, and also develop therapies that will have a big impact on the prevention of disease, in this case, COVID-19 vaccines. But if we look at different trends in the major diseases such as ischemic heart disease, we've seen great successes through prevention and treatment combined. And if we look here at this is just showing changes in deaths per million women. This is just a graph for women, deaths per million population overall. The yellow describes the changes in ischemic heart disease deaths over the decades. And as you see, that this has really fallen quite dramatically over the last 20 years or so. We've seen falls in other diseases such as cerebrovascular disease, but dementia, a major killer, has seen an increase in its the deaths and the prevalence, partly due to increasing recognition and recording on death certificates, but also because we've made successes in other areas, so that dementia is now the major cause, the most common cause of death in the UK. So it's clearly a priority from individual and societal level to prevent the diseases that cause dementia. And Alzheimer's disease is the focus of my talk today. And we'll look at reducing risk factors or the prospects for treatment and or both. So I'll start with risk factors, and these include those we really cannot do very much about, such as age, the most important risk factor for Alzheimer's disease. There's increasing risk of if you're female as opposed to male, and there's increasing risk with a family history. A word first on the disproportionate impact on women. It was International Women's Day only last week, and dementia is more common in women. Of all people with dementia in the UK, approximately 2/3 are women, so 2-to-1 ratio to men. But in addition, women do more caring of people with dementia, so a disproportionate impact and burden. A major cause of worry is around people's risk because they've got Alzheimer's disease in their family. And it's true that a family history of Alzheimer's disease does increase one's own risk, but this very much depends upon the detail of who has been affected in your family. Is it a first-degree relative or more distant? And also the age at which they're affected. So for the autosomal dominant Alzheimer's disease, where a gene is highly penetrant and will be deterministic, will cause Alzheimer's disease if you've inherited it, this is very rare indeed. Less than 1% of all cases, but it has provided great insights into disease. There are three main genes: presenilin 1, the most common, APP, or amyloid precursor protein, the second most common, and much less common is presenilin 2, and there are other forms, rarer causes too. These autosomal dominantly inherited diseases have very young onset, typically 30s, 40s, 50s or 60s, but they can be later too. And every family member at first degree relative, such as children, are at 50% risk and at a predictable age, the age at which your parent became affected in one of these families is the most likely age at which you yourself will be affected. But overall, at a population level, it isn't these rare autosomal dominant genes that account for the major impact in terms of inheritance. The apolipoprotein E gene is the major genetic risk factor, and there's a very common allele, the E3 allele, and E4, which is increases your risk, is much less common, and even less common is the E2 allele, which is somewhat protective. And ApoE4 increases one's risk of Alzheimer's disease in a dose-dependent manner. So if you've inherited one E4 allele from one of your parents, then you have approximately 3 times relative risk, lifetime risk of Alzheimer's disease. And it probably will bring your onset earlier than would be otherwise the case. But if you've inherited an E4 allele from both your mother and your father, then you're at 9 or 12 times risk if you're homozygous for ApoE4. And the reason why this has a major impact at a population level is because 20 to 25% of the UK population, is typical for populations around the globe, have a 1 E4 allele. So increased risk with a common risk factor accounts for a major part of the inherited or the family history association of Alzheimer's disease. And there are many other risk factors that account for our polygenic risk overall, but ApoE is the most important of these. So there's not much we can do about our age, our sex, or our family history, though there are a number of potentially modifiable risk factors. And I've just listed a few here. We know a lot more about the risk factors that are associated with all-cause dementia. So not specifically Alzheimer's disease, and often are detail on which of these risk factors relate to vascular dementia or Alzheimer's disease or all-cause dementia is less well defined. But these include risk factors that have been recognized for a very long time to be important for ischemic heart disease and stroke, vascular risk factors. So what is bad for your heart is also bad for your brain: smoking, blood pressure. And there are others where there are associations where we can see the link, such as head injury, a major risk factor. But there are others where we're less clear about the causality or the mechanism involved. Whether you have too little or too much sleep seems to be associated with risk of dementia. There's an association between depression and dementia, and what actually is the direction of the causality can often be unclear, but also education, which is a protective. The more education you have, you are relatively protected from dementia, and hearing loss, which increases your risk of dementia. And some of these risk factors clearly are better addressed at a societal level by governments, air pollution being one that has been recently recognized to be important because it affects so many people. And some effects may have their influence many decades later. So the quality and amount of education seems to be associated with a lower risk of dementia across the life course. And these risk factors do have different impacts at different points across the life course. And the take-home message is that we should be addressing some of these risks in midlife, whether that is hypertension or some of the other cardiovascular risk factors. But of course, there are many other reasons, in addition to reducing our risk for dementia, to address many of these risk factors. And what's clear is that we have been making a change. So age-specific prevalence has been falling in some countries. And this study by Carol Brain and colleagues, the CFAS, Cognitive Function Aging Study, where they looked at, in 2 waves, they looked at the comparison of prevalence of dementia in people older than 65, and did that, and you can see here in blue, in the first wave, and mapped out the estimated prevalence of dementia in the population at different age groups, at different ages. And then when that was repeated approximately 2 decades later, we can see that there's a lower prevalence pretty much across all these age groups. And what's the cause of that? Well, we don't really know, but there were clearly improvements since the 60s. And as you may remember from that life course diagram I showed you, the impacts of treating risk factors in the middle ages, in one's middle age, is important. So there were improvements in treating blood pressure and other risk factors in the 60s, 70s and 80s, and that may have been what was feeding through. So what about treatments, therapies to slow or to prevent Alzheimer's disease, as opposed to addressing risk factors? And particularly, I'm going to focus on Alzheimer's disease rather than all-cause dementia, because therapies that are aimed at disease modification tend to be specific to a particular disease. So once again, we could aim our therapies at preventing pathology starting in the very first place. And there are good examples of this. So that may be at a population level or targeting a particular risk group, genetic or otherwise. Secondary prevention is when we detect a pathology already being present, but we provide a treatment, intervene to prevent its effects or its progression or its manifestations. And a key requirement, if we're going to do this, is to be able to detect that pathology at a pre-symptomatic stage when people are well, and have enough time to alter the trajectory of the disease. But clearly we need effective therapies. And that has been a very, very long time coming. But the goal is that if we can delay onset in a late life disease, such as Alzheimer's disease, where the majority of people with Alzheimer's disease are in their 70s or 80s, we will have a major impact on prevalence, because we will maintain function and quality of life, and then people will die of some other cause. And the estimated effect of a 5-year delay in onset, this here is, this graph relates to US dementia prevalence, but we would see similar things, is that after a lag period, we might reduce the prevalence of dementia by 30, 40 or 50%. So when do we need to treat, or when would we as individuals want treatment? Again, is this before the disease starts? And that may be our greatest opportunity, maybe easiest to intervene early on, and that certainly is when there is most function to save. But there are counter-arguments which relate to having to take a therapy maybe for decades, as I'll show, which may have side effects and burdens. But there's been a long history of failed trials in Alzheimer's disease, and they've been ascribed to different reasons, and they may be all of these in combination, of course, is first of all a rather nihilistic view that neurodegeneration and disease of the brain are just too hard, or that the wrong targets, the wrong molecular pathology were targeted, or the wrong stage, or that we've provided our interventions at too low a dose, too little, or that we've given it too late. But if we do want to treat really early, how do we detect early changes? And I'm going to take us back a little bit now to talk about what we've understood over the last few decades about when changes are detectable, and this pre-symptomatic period that is increasingly clear in Alzheimer's disease. So the benefits of earlier intervention, rather simplistically, are if there's fewer neurons already lost, there's more to save. And it's striking, I think, to look at MRI scans such as these. This is somebody who went into a clinical trial of a therapy for Alzheimer's disease. And if we look here at the hippocampi, these are really devastated already. And if you're using as an outcome measure a memory score, it would be very hard, in my view, to be able to show a benefit. The hippocampus being an early site of most typical amnestic-led Alzheimer's disease, and the hippocampi being a key marker on MRI imaging diagnostically. And by the time actually people come along for a clinical diagnosis, the hippocampus is already 10, 15, 20% smaller than aged match control individuals, people, healthy subjects without Alzheimer's disease. So clearly we need to, we've already had neurodegeneration by the time people make a diagnosis typically. How long is that period? Well, we know a lot more now, but even just by thinking about hippocampal atrophy, we can get a bit of a clue. If the hippocampus is down by 20% by the time people have a diagnosis, we know that hippocampal atrophy rates are only 3 or 4% per year at this stage. So to have got to this stage, this amount of loss, the disease must have been present, causing neurodegeneration for 5, 6 or more years prior to diagnosis. So you're already losing a lot of brain tissue, a lot of critical brain tissue before a diagnosis. So we may need to be able to prevent this. We'll need to go in even earlier. But understanding the time course and how early these changes occur, we've had insights from a lot of familial AD studies, those rare families I mentioned early on. And by studying people who are at risk of familial disease, because there's a known gene in their family, that we can track changes and follow people in a feasible manner for decades beforehand and see the evolution of changes. And families led to our finding the first genetic causes, which have helped our understanding. And I show here Carol Jennings, one of the member of one of our patients, who wrote a remarkable letter to John Hardy and Martin Rosser 30 years ago or so, saying that I think my family may be of help to your research. And she was absolutely right, because that led to the first genetic finding of an association between a mutation in the amyloid precursor protein, or the APP gene, and Alzheimer's disease. And that caused a lot of excitement at the time, that there would be that this was a genetic breakthrough and this would unlock a cure. Now that's been a long time coming, but I will come back to that prediction to show that I do think that these families have helped, not just in our understanding disease, but directly to our finding of new disease-modifying therapies. So this is a series of MRI scans registered to baseline, so matched to baseline, so we can see the change of somebody with one of these mutations. So this is a first scan, then a second, and then a third, then a fourth, and then a fifth, and then a sixth, and then a seventh, and then an eighth, and ninth. And this is a progression annually. And I hope what you've been able to see there is that the disease, in terms of its damage to the brain structure, the atrophy, the increasing spaces, the shrinkage, is progressing over insidiously, but progressing over several years. And if I show this in a panel, so that we can see here in the top left the baseline, and here is a scan 4.5 years later. If you look, the ventricles are enlarging, that space within the brain, and we can, if you look carefully, you'll see that the hippocampi are also shrinking. Color that red to make it easier to see those changes, and you can see that several years before symptoms, we are having what is likely to be irretrievable, irreversible loss. Showing that as a graph, this is now whole brain volume. that we can see these changes occurring before symptom onset. So a crucial window where we're already losing cells, brain cells and function, and where the disease may be gathering momentum and be harder to stop and slow. And these are just showing a number of individuals in blue who are the do not carry the mutation, their family members who are not carrying the genetic mutation, so they're not at risk, and in red, those mutation carriers. And what I hope you can see here, this is all relative to here is 0 when a diagnosis is made, and you can see these declines at almost linear, but at different rates in different individuals as people approach. But this brain cell death that I'm showing on the MRI scans at a macroscopic level, that's a final common pathway. There are many processes, many pathological processes upstream. So how might we see these changes, these molecular pathology changes? These are the changes that Alzheimer could see, but only after death. And over the last decades, we've improved our ability to image molecular pathology directly with PET scans, positron emission tomography scans, so that we can give people a tracer and then scan them, and that tracer will stick to particular molecular pathology and be retained in the brain and show up here, coloured red, to show an amyloid PET scan. And we know that from amyloid PET studies that deposition precedes cognitive decline. On the left, these are two of my patients. On the left, somebody with very mild cognitive problems already, with lots and lots of amyloid shown in the hot colours, yellow and red there, compared to somebody who also had complaints of memory, but there's really no amyloid. And these have been shown by many, many studies worldwide to be predictive at some often uncertain later period of conversion to Alzheimer's disease or not. And we now have fluid biomarkers as well as amyloid PET scans, fluid biomarkers such as assays that can detect certain proteins within the cerebrospinal fluid after a lumbar puncture. And we know that there are several measures that reflect the buildup of amyloid plaques in the brain, such as a reduced level of A-beta peptides, A-beta 42, within the CSF. So a lower level, and this is on the y-axis here, putting people at being a marker of Alzheimer's disease, and a higher level of tau, a marker of neuronal damage, of axonal loss also. So a combination of low A-beta and high tau, identifying in red those individuals who are going to go on to develop symptomatic Alzheimer's disease. And this has been shown to have good sensitivity for disease versus controls. Blood biomarkers have generated a lot of excitement recently because, of course, these are much more accessible and available, and for a long time it was felt that it would not be possible to get the sensitivity that we would need to detect pathology within blood. But in fact, we now have markers that can show changes in the A-beta peptide or changes in phospho-tau. And there are different phospho-tau moieties, and I'm showing you one graph here in pre-symptomatic changes in familial Alzheimer's disease in the families I've mentioned. Here, a low level of this p-tau 181 marker in non-carriers, a higher level in people who carry a gene but are pre-symptomatic, and an even higher level in those people who are already symptomatic. So this offers the prospect of an easily available, cheap, accessible, low burden test which could be applied worldwide for Alzheimer's disease, and there is great progress being made at the moment. But all these markers have shown us that we've essentially got a long prodromal pre-symptomatic period that we now can detect in life with brain imaging, with markers in CSF and blood. And these are accessible both to measure the onset or predict onset of that pathology and to track the effects of therapy. And that has opened up a new era in clinical trials, which have these markers built into the studies, both for inclusion in the trial and in monitoring the effects of the therapy. Now, if we just think about this cascade in a slightly different way, and what we have here is on the y-axis measure of abnormality of a particular marker. This cartoon or schematic shows that we think that amyloid may be one of the earliest markers to become abnormal, and then there are a range of others which ultimately lead to cognitive decline and functional impairment. But what we've got then, in a way, we can think of a couple of phases with regard to this lecture. There's primary prevention, which is before the red curve goes up, before amyloid reaches some sort of critical level, and then secondary prevention after amyloid. And this window between amyloid being accumulated in the brain and cognitive decline sufficient to be recognized as mild cognitive impairment is probably somewhere between 15 and 25 years. And then thereafter, this symptomatic phase of the disease, the dementia phase, which is maybe typically 5, 8, 10 years, can be seen to be only a small proportion of the whole disease course. So for pre-symptomatic treatments, there are a number of challenges. We need ways to identify the individuals, to confirm the presence of the pathology being targeted, particularly if our therapy is either expensive or burdensome or has a high risk of side effects. We need to know that we are providing a therapy to the people who may benefit, and also to be able to track the effects of the therapy on these pathologies at a pre-symptomatic stage, because we won't, by definition, have clinical markers that can show any decline while people are pre-symptomatic. But most importantly, we need treatments that can slow progression, and these two things go hand in hand. Progress in imaging and biomarkers can accelerate our discovery of treatments, but only with discovery treatments may we be able to really understand exactly what some of these biomarkers show in terms of response to therapy. And a major focus has been on targeting amyloid and anti-amyloid therapies, and there have been a number of different approaches trying to alter the production of these amyloid beta peptides in the first place, but other approaches where we try and improve clearance. And there's a whole host of other pathologies, and there are the field has been divided into which is the right target to really focus on. But the last 2 decades has shown a great focus on amyloid and the use of immunotherapies, in particular antibodies against this A-beta peptide or its different conformational forms, to try and improve clearance, use the body's own immune mechanism to remove these toxic moieties. And it's been a long journey. And that journey starts with a remarkable finding by Dale Schenk and colleagues, which is really in the last century, when they immunized a mouse model for Alzheimer's disease. And mice are clearly quite different to humans in terms of how they express pathology, but this mouse model, when immunized against amyloid, against beta amyloid, showed dramatically reduced amyloid pathology. And that led to this cover of Nature, which had the idea that we might be able to purge or remove from the brain amyloid plaques. In the last more than 20 years, we've been great promise and a number of disappointments. The active immunization in humans was halted in 2002 because it caused inflammation in the brain. Clearly, the vaccination led to individuals in developing, producing antibodies, just like we do with COVID-19 vaccination, and there were different levels of immune response, and that had a different level of reaction within the brain, with a number of participants, 6%, getting meningoencephalitis, and the trial was stopped early. And since that time, there have been a number of MABs, monoclonal antibodies, trying to target the A-beta pathology in its different forms. And these are a number of trials that have therapies that are no longer being taken forward in development, and these are rather more recent ones, of which two, aducanumab and lecanemab, have both received approval from the US FDA as a therapy for Alzheimer's disease. I'm just going to talk for a word about lecanemab now, which is the most recent of these, but we need to think where this long journey of development of this antibody came from. And once again, to acknowledge the contribution of families. And the original observations were made in familial Alzheimer's disease by Lars Landfelt and colleagues in looking at a family from northern Sweden who had this rare, what was called the Arctic APP mutation, which caused particular pathology with these A-beta protofibrils, and did not cause the conventional amyloid beta plaques. They caused an unusual, an atypical plaques. And this really gave a pointer to maybe the protofibril was a good target for immunotherapies. And here is the a paper which has really caused great excitement, showing that lecanemab therapy, an monoclonal antibody targeting these with a high affinity for these soluble amyloid protofibrils in a large phase 3 double-blind controlled trial in people with not familial Alzheimer's disease but sporadic Alzheimer's disease at a mild or early stage. Well, what did this show? What it showed is what has been shown by other therapies, that lecanemab was able to remove amyloid as far as we measure it by amyloid PET binding. So we see in blue here the placebo level, the placebo individuals who did not receive the antibody, not much change in their level of amyloid PET binding. And with a particular scale called the Centiloid scale, the mean amyloid binding was around 75 to 80 in the placebo and the lecanemab arms here at 0. What we're seeing on the y-axis is change. Lecanemab produced a rapid and dramatic removal of amyloid from the brain, as measured by PET. So over this 18-month study, the mean amyloid level in the lecanemab group fell from 75 to 80 to, on average, 23 centiloids. And that was actually below the threshold for amyloid positivity. So by the end of the study, the majority of the individuals who received lecanemab would no longer have been eligible to go into the study in the first place. They would not have had enough amyloid PET binding, not enough amyloid in their brain to have been included in the study and to have received treatment. So that's all well and good. Other therapies, including the original immunotherapy, the vaccination study, did show that we could remove amyloid from the brain, but we have failed to show convincingly that this translated into any clinical benefit. And in fact, had led many people to suggest that really this wasn't the right target if trial after trial was not able to show benefit. So lecanemab did achieve its pre-specified primary endpoint. This was a change in a composite score called the clinical dementia rating sum of boxes score, which ranges from 0 to 18. And we see here in blue the decline in the placebo group, who lost, had a change of 1.67 or 1.7 points on this score, and less of a change in the lecanemab group. And that is equivalent to about 27% slowing. It's not a huge difference in absolute terms here. In fact, this difference is not that different to some of the symptomatic therapies we have at the moment. But the fact that we may be slowing clinical decline as well as removing the underlying pathology has led to hope that we may be changing the disease process in a way that may be sustainable and may have longer term benefits. It also hit all its secondary endpoints, And I think it's really important to note here that that included not just other cognitive scores, but the burden on partners, a 38% less decline. Now, these are biologically active therapies, and these monoclonal antibodies have largely all had a particular feature called ARIA-A, amyloid-related imaging abnormalities associated with edema, and this was 1 in 8 in the lecanemab group had these ARIA-E. Most of them were asymptomatic, as opposed to almost none in the placebo group. There was no increased mortality in the double-blind phase, but cerebral hemorrhage was reported in the open label in a small number of individuals who were receiving lecanemab, but also were given either thrombolytics for a stroke or blood thinning therapies. So how important is this? How clinically meaningful? Well, that's been a subject of great debate, and I've just put up a few of the headlines to show that there's a range of views from whether this is hope and challenges or whether it's Russian roulette. And there are many questions remain. Perhaps the most important being, are these benefits sustained and cumulative? Is a 27% something that you gain with each extra 6 months beyond that 18 months? Does that continue? Because then really we will be slowing people and keeping people longer in mild states. Will they be even greater if we go earlier in the disease? But these raises huge challenges for clinical practice. We will absolutely need to be able to diagnose people in a timely way, because up until now, our therapies, symptomatic therapies, it didn't matter if in terms of the ultimate progression of disease, if they had a diagnosis slightly later. Now it will be that we are in a similar sort of ballpark that we have seen with cancer, that a delayed diagnosis will change the ultimate outcome. And diagnosis rates in the UK are just 62%. Our time from symptoms to diagnosis is around 3 years. A small proportion even get an MRI, and a tiny proportion get amyloid PET or CSF. The treatments are likely to be expensive and complex. Lecanemab, for example, involved IV infusions every 2 weeks and required multiple MRI scans to monitor for this ARIA-E. And there will be increasing care and support needs, as we've seen in other diseases. So I'd like to end by saying prevention of dementia is possible now with modifiable risk factors, and it will be with therapies, I hope, in the near future. There'll be a long prodromal period when we will be needing to think when pathology is measurable, a window of opportunity available that we want to treat. There are huge challenges, but there are also prospects and hope for our patients and families after so long. So my thanks to you for listening, and also to the patients and families who help in research. And perhaps these families may well unlock the cure. Thank you.
So thank you so much, Nick. That was a really beautiful account of just how far we've come in terms of understanding, being able to diagnose dementia. And thank you also for painting a picture of why it can take quite so long to unravel some of the mechanisms underlying these diseases. So it's exciting to be at this point of having potential treatments for Alzheimer's. But I wonder whether you'd like to comment on what the cost of that is going to be to the NHS in terms of these treatments, obviously, which aren't, as you mentioned at the end, are not going to come cheap, and everything that surrounds giving those treatments and monitoring the patients.
Yes, absolutely. Huge challenges, and just we don't really know what the cost would be to the NHS of the therapy itself. There's been speculation that this would be of the order that for lecanemab of the order of $25,000 a year. Higher than that was suggested originally for aducanumab. But that doesn't take into account the costs of where we're going to administer these infusions, the MRI scans, the fact that people would need some assessment of that they had amyloid pathology, amyloid PET, CSF, or blood biomarkers. So I don't think anybody's put a number on it, and it's likely that it will start probably in quite a restricted way. But these therapies are not for the faint-hearted in terms of putting yourself forward, and they certainly will be a challenge to the NHS.
So just to follow up on that, you say these therapies are not for the faint-hearted, and again, we'd like to expand a bit on that. What are the difficulties of going through these sorts of treatments?
Well, yes, certainly seeing and people going into the trials, which I guess is the closest we've got to what it would be like in therapies, huge commitment required. An infusion every 2 weeks. Just think about what that means for your holiday planning. And of course, if we were able, as the people do go through huge burden and difficult treatments for chemotherapy, for example, for cancer, but we often hope to get people in remission and then they can stop treatment. And so that would be one hope that you might see. You might be able to lower an amyloid level, for example, in people with Alzheimer's disease, and then they could come off treatment. We really need, a real pressure would be that we don't have to deliver this with IV infusions. There are formulations being tested at the moment, subcutaneous, which would be much less burdensome. But as many people on this call will know, we've had other diseases where the first therapies were very burdensome, and we've had to really change, gear up services, MS, HIV, for example.
So anyway, it's exciting to be at a point of thinking we might need to tackle that for Alzheimer's. We've got some further questions here. So you mentioned needing to start treatments early, and just how early do you think it may be important to start treating for Alzheimer's disease?
That's a great question, but it's not easy to say. So in a late onset disease, as I think I showed, if we can delay onset by a few years, you make a huge impact upon the number of people with disease, because bluntly, people die of other things if we're treating people at old age. I think what this is showing is that we can slow disease if these results that I showed do hold up when people are already symptomatic. And many people felt that we would need to treat before neurodegeneration or even before amyloid. And I think that gives great hope, because that would be quite something, to having to treat 10, 15 years before people were going to be symptomatic. I think we will be wanting, needing may not be the right answer, we will really be wanting to treat people when they either have no symptoms or very, very mild symptoms.
Thank you. So we got a question in the chat here, which is, would you be willing to elaborate more on the mechanisms behind the side effects of the amyloid immunotherapies?
Yeah, certainly. So what we know is that amyloid pathology occurs both in the brain parenchyma, but also involves the blood vessels in cerebral amyloid angiopathy. And the vessel wall of these blood vessels in the brain gets almost replaced by amyloid, or certainly there's amyloid throughout the vessel wall. And the theory about how ARIA occurs is that the immunotherapy is ripping out amyloid out of those vessel walls, which then can cause leakage, which can cause microhemorrhages, which is one form of ARIA, ARIA-H, but it also can cause ARIA-E, which is the more worrying, where you get edema in infusions. And that's thought to be due to a breakdown of that blood-brain barrier, greater ingress of antibody locally in that area, causing an immune reaction, causing swelling, and can make people really unwell. It's usually self-limiting, and the trials up until now have focused on if people were symptomatic, they would stop the immunotherapy. So that's the need for the monitoring.
Thank you very much. Another question here. Do Alzheimer patients naturally have anti-amyloid beta autoantibodies in the brain, CSF, or blood? Or would they only generate them after receiving monoclonal antibody treatments?
Again, an absolutely great question. So there are, people can have a immune reaction naturally and it's relatively small individuals, get a sort of an immune reaction to their cerebral amyloid angiopathy, and antibodies are picked up in these situations in the CSF. Have been measured, but it's a very small number. So we've seen within the families I've studied where they have a good immune system, they're young, and they have lots of amyloid angiopathy, amyloid in their blood vessels as well as in the brain. A very small number of individuals have spontaneous ARIA. And in the trials, when it's been looked for, because most of it's 80% is asymptomatic, in the trials it's 1 or 2% in the placebo group.
Okay. Thank you. Another question here. Are CSF and blood biomarker tests more effective and cheaper at detecting early Alzheimer's disease onset than imaging?
Yeah, no, very, very relevant question. Blood biomarkers would be a lot cheaper. And depending on how you cost it, the amyloid PET scans are a few £1,000s. So CSF is likely cheaper, particularly if it's done effectively. And the assays for once the CSF is taken are relatively cheap. They're in the order of tens or hundreds of pounds for the whole package, so much less than an amyloid PET. CSF is very comparable to amyloid PET in its ability to the CSF markers of amyloid and phospho-tau within the CSF. It's very comparable to amyloid PET. The jury's probably out with the blood biomarkers still. It's a difficult medium to work with, blood compared to CSF. It may well be that we have that as a first pass, screen with blood, and then move on to a second level. But clearly, the hope would be that would be equivalent or non-inferior.
Thank you. Can results from familial Alzheimer's disease generalize to sporadic Alzheimer's?
Well, some clearly. I think there's these trials were not done in familial Alzheimer's disease. There are trials ongoing in familial Alzheimer's disease. International consortia do these, and they are looking both at secondary prevention when people already have amyloid, as well as primary prevention. What's interesting is that does look like that at least these therapies will work across both familial and sporadic Alzheimer's disease, which is perhaps not surprising because they end up with the same sets of pathologies in the brain. But of course, there'll be other therapies that will only be in familial Alzheimer's disease. A real excitement, as in many other diseases, is the idea that we might have genetic-based interventions where we would actually target the specific genetic abnormalities that are causing Alzheimer's disease in these families, and they would clearly not be relevant in the same way to sporadic Alzheimer's disease. But targeting the proteins with gene-based therapies that Alzheimer identified and are now the hallmarks may generalize across both forms of the disease.
Okay, we've got a question from a member of the public here. You said at the beginning that education reduces the risk of getting the disease early on. Is there a biological explanation for how that occurs?
Oh, that's a great question. The short answer is I don't really know. There are things which you can sort of do a bit of a hand-wavy exercise around building up cognitive reserve, and that you will have education will lead us to having better links and greater neuronal densities and things like that. But hand on heart, I don't really have the answer to that. I don't know whether, Anne, you do.
I don't have the answer to that either, Nick, but I think it's good advice to us all to keep active both physically and cognitively. Okay, so another question here. What about other diseases? My relative has FTD. So this treatment, will this help him or not?
No, these are very specific pathology targets. But what I do think in terms of these other neurodegenerative diseases, I hope that therapies, and it's the beginning of a journey. This is there's a lot of question marks about the clinical meaningfulness, all the things I raised, and really challenging. But I do hope that might end the sort of a long period of nihilism, that there's nothing you could do about these brain diseases. They're just too hard. And so the idea that we can target a pathology, whether it's in Alzheimer's disease or in some of the frontotemporal dementias, and make a difference, I think will stimulate research. These anti-amyloid therapies will not be relevant for your relative, I'm afraid, but they may generate more trials, more therapies, and should be a source of hope.
Thank you. We've got another interesting question from a member of the public. So what's the best water filter to clean water? What about gut microbes? Please discuss.
Oh my goodness. Well, I don't think I'm the right person to talk about water filters, I'm afraid. I haven't really got the decent answer. Perhaps anybody listening could put something in the chat as to answer to that. They're probably people a lot better qualified than I am.
But I guess the second part of the question, do you think gut microbes are going to turn out to be important in Alzheimer's? Or?
Well, there have been sessions at this conference and in many other conferences about how important they are. Again, I don't feel I have great expertise there.
Okay, thank you very much. So I think, oh yeah, so one last question. Is it going to be necessary to have screening programs for Alzheimer's disease or for amyloid?
Well, people have been asked for a long time, once we started having amyloid PET scans or blood biomarkers, or even showing that the changes that occurred early with MRI, there have been arguments, and people have put themselves forward for, well, I'd like to know, I've got something in my family, I'd like to know whether I'm getting Alzheimer's disease. But until we can show that there is the clinical benefit is there for early intervention, I really don't think there is an argument for screening. I mean, people have very strong views on that. Some people say, I really would want to know because I'd want to plan my life. But as we've seen in other diseases, whether it's breast cancer, that you really need to show at a societal level cost, benefit, and burden. So where do I think we will end up? I think it's not for now, but in the future, I think we will be screening people, perhaps after a certain age, or perhaps picking things up earlier than we do at the moment. I mean, it's shocking that people can often have years of symptoms and a great delay before they get a diagnosis. That was never a good thing, and it now will have much more implications if we delay people's diagnosis when there's a therapy that could slow disease.
Absolutely. Thank you so much. Thank you. That was a really illuminating lecture, and thank you for so beautifully putting this into context, and for answering so many questions. So thank you very much indeed.
Thank you very much.